Okay, let's unpack this. We have all had that moment. Maybe it was you, maybe it was your kid screaming at 2 in the morning, where an ear infection feels like the absolute center of the universe.
Absolutely.
It hurts, it throbs, and it just ruins your week. But generally, we think of it as a manageable misery, right?
The typical experience, yes. You get some antibiotics, you wait it out.
And life goes on.
Exactly. And because it's so common, we tend to get complacent about what is actually happening inside that tiny space. We treat the ear like a simple closed box.
But today, we are shattering that illusion. We are diving into a stack of lectures from ENT specialists that paint a very, very different picture.
A much more serious one.
We're looking at chronic suppurative otitis media, or CCMM. And specifically, we are looking at a scenario where the infection doesn't just annoy you, it goes on a rampage.
That's a vivid way to put it, but it's medically accurate. We're talking about complications, and not just my ear still hurts, complications. We're talking about an infection that decides to breach containment. It eats through bone, it hijacks the nervous system, and it can even create these pockets of pus abscesses in your neck and face.
The phrase that stuck with me from the reading was the breakout. It sounds like something from a prison movie, but it's happening inside your skull.
It effectively is a breakout. The middle ear is a fortress of bone, but if the conditions are right, the bacteria can find the keys, pick the locks, or just, blow up the walls.
So today our mission is to map out the extracranial complications. That means everything happening outside the brain cavity itself.
Exactly. We're not talking about brain abscesses or meningitis yet. That is a whole other level of terrifying we might get to another time.
Today's about the face, the bone, the neck, the balance system. But before we get to the graphic details, and fair warning, I have to ask the big question. Why? Millions of people get ear infections. Why does one person just get a fever and another person ends up with facial paralysis?
That is the million-dollar question. And the source material is very clear. It is rarely just bad luck. It is usually a perfect storm.
Perfect storm.
You need a specific alignment of risk factors to turn a standard chronic infection into a spreading disaster. It's almost like a recipe for catastrophe.
Okay, so let's look at the ingredients for this storm. Who is actually at risk here?
Well, if you look at the demographics, age plays a massive role. It follows this kind of U-shaped curve. The complications are most common in the first decade of life, so very young children. And then the risk spikes again in the elderly.
And is that just because their immune systems aren't quite firing on all cylinders?
Precisely. In kids, the immune system is still learning the ropes, their anatomy is different. And in the elderly, the immune response is fading. But it's not just biology. The sources place a huge emphasis on environment.
Socioeconomic status.
A major driver here. If you're living in overcrowded conditions or you have poor hygiene standards due to poverty, you're constantly exposed to pathogens.
That makes perfect sense.
And it's about access to care. If you can't easily get to a doctor, a manageable infection is allowed to just fester. It simmers. Overcrowding, poor nutrition, limited health education, they create a breeding ground.
So the body is fighting with one hand tied behind its back.
Exactly. So you have a vulnerable host in a tough environment. And then, of course, there are the bugs themselves, the invaders.
Right. The lectures didn't just say bacteria. They called out superbugs.
Yes. The virulence of the organism matters immensely. We aren't usually dealing with your garden variety, easy to kill bacteria here. The lectures specifically call out some heavy hitters.
Like what?
You have Streptococcus pneumonia, specifically type 3.
What makes type 3 so special? Is it just stronger?
It's not just strength, it's weaponry. Type 3 produces these specific enzymes, autolysin and hemolysin.
Those sound like villains in a comic book. What do they actually do?
They're essentially chemical excavators. Hemolysin destroys blood cells, and autolysin helps break down tissue.
So they literally dissolve the structure standing in the bacteria's way.
They clear the path, precisely. And then you have Haemophilus influenza, Pseudomonas aeruginosa, and the one everyone fears, MRSA, methicillin-resistant Staphylococcus aureus.
The ones that just laugh at standard antibiotics.
Exactly. So you have a patient with low immunity, living in poor conditions, infected with a chemically aggressive superbug. That's 3 strikes.
And there's a fourth one, immunocompromise.
Yes, often systemic. Patients with uncontrolled diabetes, AIDS, or those on chemotherapy, their bodies just can't build the wall. Uncontrolled diabetes is a huge one. The sugar-rich blood is basically fuel for bacteria.
There's one other factor the sources mentioned that really stood out to me because it feels so preventable. The role of inadequate treatment.
This is critical. It's the concept of doing just enough to hide the symptoms, but not enough to actually kill the bacteria.
Like painting over rust on a car.
That's a perfect analogy. Maybe the dose was too low. Maybe the duration was too short. You took the pills for 3 days instead of 10 because you felt better.
We've all done that.
Right. You knock the infection down so the pain stops, but you don't knock it out. It lingers in the dark corners of the bone. It learns, and it waits.
It turns an acute problem into a chronic time bomb. Okay, so the infection is there, it's angry, and it wants to move. How does it get out? I mean, the temporal bone is one of the hardest bones in the body, isn't it?
It is incredibly dense. But to a persistent infection, bone isn't a wall, it's just a very slow door. The most common pathway is direct bone erosion.
Literally eats the bone.
In a sense. In acute cases, you get a process called hyperemic decalcification. The inflammation increases blood flow, which it changes the local pH and literally sucks the calcium right out of the bone.
Yeah.
It turns hard rock into soft mush. And in chronic cases, you have something called cholesteatoma.
Which is that cyst-like growth.
Yes, and it produces enzymes that physically digest the bone. It's like a slow-moving mining crew excavating a tunnel.
That's horrifying. But the sources mentioned other highways too, something about veins.
Venous thromboembolism. This is the Trojan horse method. The bone has a plumbing system, these tiny haversian canals with microscopic veins. They connect to the dural venous sinuses and the veins of the brain and neck.
So the bacteria don't need to dig through the bone, they just hop on the subway.
That's it exactly. They get into the bloodstream, cause a small infected clot, a thrombus, and that clot travels along these venous highways to distant sites.
And then there are the shortcuts that are already there, the preformed pathways.
These are anatomical glitches. It could be congenital, like a dehiscence.
Dehiscence is just a fancy word for a gap, right?
Yes. Some people are born with tiny gaps in the bone over their facial nerve. The door is left ajar at birth. Or it could be from trauma, an old skull fracture that healed with scar tissue instead of bone.
And scar tissue is not as tough as bone.
Not even close. It's a weak point. Or even previous surgeries. If you've opened the door surgically in the past, the lock is never quite as strong.
So the bacteria have motive, means, and opportunity. Now let's get to the crime scene. The sources divide these complications into intratemporal and extratemporal. Let's start intra, inside the bone.
Right. Intra meaning inside the temporal bone. The first and most significant complication here is mastoiditis.
The infection next door.
Yeah.
The mastoid is that hard bump right behind your earlobe.
Correct. And inside, it's like a honeycomb of air cells. Now, mastoiditis comes in two flavors. First, you have acute mastoiditis. This is loud, aggressive, impossible to ignore.
The sources painted a very vivid picture of this, specifically the ironed out mastoid.
It's a classic sign. Normally, the mastoid bone feels rugged, but in acute mastoiditis, the covering of the bone gets inflamed and swollen. The skin tightens over it. It feels smooth, ironed out.
And the ear itself gets pushed around.
Yes, the swelling pushes the ear forward and down. You lose that crease behind the ear. It creates a very distinct jug ear appearance.
And if a doctor looks inside the ear canal?
This is the sign that really makes you sit up. You see sagging of the posterior medial wall.
Okay, that sounds technical. Break it down.
The mastoid air cells sit right above and behind the ear canal. When they fill with pus under high pressure, the bone separating them from the canal starts to buckle.
So the roof of the ear canal is literally collapsing.
It's collapsing downward under the weight of the infection. It's agonizing. Fever, discharge, tenderness. Because it's so obvious, it usually gets treated aggressively.
But then there's the other flavor, the one that scares me more. Masked mastoiditis.
This connects right back to our talk on inadequate antibiotics. This is also called latent mastoiditis.
That's the sneaky one.
Very sneaky. You take antibiotics for a few days, the pain stops, the fever drops. You think you've won.
But you haven't.
No, you've just killed the sensitive bacteria. But deep in the honeycomb, the resistant bacteria are still alive. They are slowly, quietly eating the bone. Silent destruction.
So how do you spot it? If there's no pain, no fever.
The clue is the eardrum. The source describes it as thick and opaque. It loses its normal pearly translucency. It just looks dull, heavy. That dullness is the red flag that something is still wrong behind the curtain.
That is terrifying. Okay, moving deeper into the skull. Petrositis. This is when the infection reaches the petrous apex.
This is a deep, deep part of the temporal bone, toward the center of the head. Now, interestingly, this only happens in about 30% of people.
Why only 30%? Is it a genetic lottery?
Basically, yes, only about 30% of people have pneumatized petrous bones, meaning they have air cells there for the infection to move into. But if you're in that 30%, you can get one of the most fascinating diagnostic triads in medicine, Brody-Nigo syndrome.
I love a good triad. Makes it so much easier to remember. What is it?
Okay, sign number 1, ear discharge. That's the obvious part. Sign number 2, retroorbital pain, a deep, boring pain right behind the eye.
Wait, an ear infection causing eye pain? How?
It's geography. The inflammation at the petrous apex is irritating the trigeminal nerve ganglion, which sits right there. That nerve sends pain signals to the face and eye.
Incredible. And the third sign?
Lateral rectus palsy.
Which means?
They can't look outward with that eye. If the infection is in the right ear, they can't look to the right. The 6th cranial nerve, which controls that eye muscle, runs right past the petrous apex. The swelling just pinches it.
So ear discharge, pain behind the eye, and an eye that gets stuck looking to the side. Brody-Nigo syndrome.
Exactly. You see that, the infection has traveled deep into the skull base. It's a classic aha moment.
Now, for something that might scare people even more, facial paralysis.
Yeah.
The idea that an ear infection can freeze your face.
The face at risk. It's a huge psychological blow, and the mechanism depends entirely on whether the infection is acute or chronic.
Okay, let's start with acute.
In acute cases, it's usually because of a dehiscence, that natural gap in the bone. The nerve is sitting there exposed, the middle ear fills with toxic pus, the nerve gets inflamed, it swells up inside its tunnel and just stops working.
But the nerve itself is still alive.
Yes, it's just compressed and angry. The prognosis is actually very good. You treat the infection, relieve the pressure, and the nerve usually wakes right back up.
But chronic cases are a different story.
Completely different. In chronic CSM, especially with cholesteatoma, the paralysis isn't from swelling, it's from destruction. The disease is physically eating the bony canal.
It's eating the wire.
It's eating the wire. The onset is insidious. It creeps up on you. And you can't just give antibiotics for this.
What's the fix?
It's a surgical emergency. You need a radical mastoidectomy. The surgeon has to open everything up, find the nerve, and physically remove the disease from around it.
And if the disease has already gotten into the nerve fibers,
Then you may have to cut out that section and do a graft, usually taking a nerve from the leg or neck to bridge the gap. It is serious, life-altering surgery.
so I've had bone destruction, eye pain, facial paralysis. What about balance?
Labyrinthitis. The infection breaches the inner ear. This comes in stages. First, you might have circumscribed labyrinthitis, often called a fistula,
A fistula is a hole.
a small abnormal opening into the bony labyrinth. Usually a cholesteatoma rubs against a semicircular canal until it wears a hole in it. The symptom here is the fistula sign.
How did that show up?
The patient is mostly fine, but if you press on their tragus, the little flap in front of the ear, or if they sneeze, they get a sudden violent burst of vertigo.
Because the pressure goes right through the hole into the balance center.
Exactly. But if you don't catch it there, it can become diffuse. And that splits into serous and suppurative.
What's the difference?
Serous is the warning shot. It's chemical irritation. Toxins enter the inner ear, but not bacteria. You get vertigo, a nystagmus, the eyes twitch, but it can be reversible.
And suppurative.
Suppurative means pus. The bacteria have physically invaded the inner ear fluids. This is the point of no return. The delicate hair cells are destroyed. You get permanent loss of hearing and permanent loss of balance function.
The inner ear is dead.
It is. It's a tragic progression from a small hole to irritation to permanent destruction.
So that covers the damage inside the temporal bone. But the title of this is extracranial complications. That implies the infection breaks out entirely.
The breakout. This is where we leave the skull and start talking about abscesses in the soft tissues. The infection erodes through the outer cortex of the mastoid and just spills out.
Let's run through the rogues gallery of abscesses. The most common is the postauricular abscess.
Right. Postauricular meaning behind the ear. You get a boggy swelling, the groove behind the ear disappears, and the ear gets pushed forward and outward. Looks like a jug handle.
Then there's the zygomatic abscess. Zygoma is the cheekbone area.
Correct. The infection tracks forward. The key sign here, and this is a great clinical pearl, is edema of the upper eyelid.
Again with the eyes. You have an ear infection, but your eyelid is swollen.
It's all connected. If you see a patient with a runny ear and a puffy upper eyelid, think zygomatic abscess. The pus is tracking right through there.
Okay, now this next one sounds like a torture method. Bezold's abscess.
Bezold's is a deep neck thread. The infection breaks through the very tip of the mastoid bone, at the bottom. It leaks out and gets trapped inside the sheath of the sternocleidomastoid muscle.
That's the big muscle on the side of your neck.
Exactly. So the pus tracks down that muscle. The patient gets swelling in the upper neck, but the hallmark sign is torticollis.
The stiff neck.
A rigidly stiff neck. They hold their head tilted toward the painful side and refuse to turn it. The muscle is in spasm because it's bathed in pus.
And it's dangerous because it can travel from there.
It can travel down into the chest. It's incredibly dangerous.
It is wild. Then we have a couple of oddly specific ones. Luke's abscess.
Luke's is unique. It's an abscess in the external ear canal itself. But the funny thing is, there's no destruction of the mastoid bone. The pus travels under the periosteum and just pops up in the canal.
And Satelli's abscess.
Satelli's goes the other way backwards. The pus tracks along the posterior digastric groove to the occipital region, so you get a painful swelling at the back of the skull.
And finally, parapharyngeal and retropharyngeal abscesses.
These come from the paratubal cells around the eustachian tube. They're dangerous because they are deep in the throat space and can compromise the airway.
So we've gone from a simple ear infection to abscesses behind the ear, in the cheek, down the neck, back of the head, and deep in the throat.
It creates a map of destruction. The infection simply follows the path of least resistance.
So when you step back and look at these lectures as a whole, what's the big picture?
The synthesis here is that CSM is a progressive danger. It is not static. It is an active biological process that is constantly looking for a way out of the middle ear.
It's relentless.
It uses veins, it uses enzymes to eat bone, it finds the cracks in our anatomy. It is absolutely relentless.
And it feels like the theme of mastoiditis is the most critical warning.
Absolutely. That is the key takeaway. In the era of antibiotics, we don't see the raging obvious complications as often. We see the subtle ones, the masked ones.
The silent ones.
Yes. The danger of treating an infection just enough to hide the symptoms but not kill the bacteria cannot be overstated. A silent ear can still be a dangerous ear.
It makes you look at a prescription for a 10-day course of antibiotics very differently.
Right.
You don't stop at day 5 just because you feel better.
Exactly. If you stop early, you are leaving the door open for that perfect storm. You are inviting these complications back in.
Well, we've covered the damage to the face, the neck, and the balance system. But here's a final provocative thought to leave you with. We spent this whole time talking about extracranial complications, the infection moving outward.
Right, into the safe zones, relatively speaking.
But the ear is also right next to the brain. The roof of the middle ear is the floor of the brain cavity. If the infection can eat through bone to get to the neck,
It can certainly eat through bone to get to the brain.
and that's the elephant in the room.
If the infection takes a path upward instead of outward, we are not talking about abscesses in the neck. We're talking about meningitis, brain abscesses, and lateral sinus thrombosis.
But that, my friends, is a deep dive for another day.